Now that we've talked about the basics of the circulatory system, let's switch gears and start talking about the cardiac cycle. This is the basis for understanding heart sounds and heart murmurs, so it's a very high-yield topic on the exam. Let's start with the top diagram, which is a pressure-volume curve for the cardiac cycle. Let's start at the bottom right of the black curve, here. This corresponds to the end of diastole. To follow this type of curve, you have to go around the circle in the direction of the black arrows. Phase 1 corresponds to ventricular contraction against a closed mitral valve and closed aortic valve. The pressure increases while volume remains the same, and this is called isovolumetric contraction. In phase 2, when the aortic valve opens, seen here, volume suddenly starts to decrease as blood is ejected, but pressure continues to rise gradually. This corresponds to systole and ventricular contraction. After the aortic valve closes, you get to phase 3, seen here, which is isovolumetric relaxation as the ventricles relax with closed valves. Finally, phases 4 and 5 happen after the mitral valve opens, seen here, allowing for blood to flow into the ventricle at low pressure, which corresponds to diastole and ventricular filling. This makes up the whole cardiac cycle. The other colored curves on this image represent changes in the normal cycle. The green curve results from increased preload. In this case, the maximum volume during diastole is higher, but since the stroke volume is also increased, the other values remain the same as the heart compensates for the higher volume. The brown curve corresponds to higher contractility. In this case, the entire curve stretches out. More blood fills into the heart during diastole, but much more is also injected during systole, so that the end systolic volume decreases. The blue curve corresponds to increased afterload. Since it's harder to get blood out of the heart, the pressures required are much higher, but the volume that actually leaves the heart is much less. The next diagram shows pressure over time in the course of the cardiac cycle, and it also correlates this with heart sounds and an EKG tracing. We'll deal with EKG findings later, and now let's just focus on the heart sounds. One simple way to think about heart sounds is that they normally correspond to valve closure. So S1 corresponds to closure of the mitral valve, and thus the beginning of systole, whereas S2 corresponds to closure of the aortic valve, and thus the beginning of diastole. Also, don't forget that something similar is happening on the right side of the heart too, so that S1 also corresponds to the closure of the tricuspid valve, and S2 also corresponds to the closure of the pulmonic valve. Other details about S1 and S2, as well as abnormal heart sounds like S3 and S4, can be found here. The information at the bottom about splitting will be covered in the next fact. This graph also contains information about the jugular venous pressure curve. You should spend some time learning this, although it's not entirely high yield on the exam. Before we move on, let's take a minute to go over what we've learned so far about heart sounds. Ready? Immediately after you hear the S1 sound in a normal heart, which valves are open? This is a difficult question, but the answer is none of them. The S1 sound is caused by the closure of the mitral and tricuspid valves, so these two are obviously closed. But if you think back to the cardiac cycle, there still has to be a phase of isovolumetric contraction before the aortic and pulmonic valves open. So immediately after S1, all of the heart valves are closed. Now that we've talked a little bit about heart sounds, it's important to cover the idea of splitting. Like we talked about, the S1 sound normally has both the mitral and tricuspid valves in it, and the S2 sound normally has both the aortic and pulmonic valves in it. Splitting is when S2, which is normally a single sound, is split into two separate sounds. The key to understanding why this happens is to think about valve closure. Anything that causes the pulmonic valve to close later will lead to splitting. This can be physiologic, like during inspiration, when more blood flows into the lungs. But it can also be pathologic. For example, any condition that delays the right ventricle emptying will lead to worsened splitting throughout the breathing cycle. And a fixed anatomical lesion, like an ASD, will lead to splitting that does not vary with breathing. The last type of splitting is different than all the rest because in this case the aortic valve closes first due to delayed left ventricle emptying. As a result, the splitting goes away with inspiration, which is why it's called paradoxical. All that information about splitting really isn't helpful without the context of cardiac auscultation. This is probably something that will seem familiar from your physical exam courses, and most of this information can be memorized, including the table of maneuvers. You should remember where the auscultation points are: aortic, pulmonic, tricuspid, mitral, spelling out apartment M from top right to bottom. This information is absolutely critical for the exam, which now has audio questions that test your ability to identify heart murmurs. Of course, it's impossible to learn everything about heart murmurs in one page, but the ones listed here are the ones that you're most likely to hear on your exam. Let's start with the systolic murmurs. The first one is mitral regurgitation and/or tricuspid regurgitation. Let's take a listen. Notice how the sound goes all the way from S1 to S2, as you can see diagrammed here, meaning it's holosystolic. If you hear this sound loudest in the mitral area, it would be mitral regurgitation, and if it's loudest in the tricuspid area, it would be tricuspid regurgitation. Next, let's listen to aortic stenosis. Even though this sound is also systolic, it sounds a lot different. It doesn't go all the way from S1 to S2, and there's a little gap on the end of each sound. Plus, it's not the same the whole way through, but it gets louder and then softer. Also, this sound would be heard best near the aortic area. The next systolic murmur is from a ventricular septal defect, or VSD. This will sound a lot like tricuspid regurgitation, and it's heard best in the tricuspid area, which can cause some confusion. One easy way to distinguish the two is that tricuspid regurgitation will become louder as the patient breathes in, while a VSD murmur shouldn't change with the breathing cycle. The last systolic murmur to go over is mitral valve prolapse. This is when the mitral valve prolapses slightly into the left atrium during systole, causing a sharp mid-systolic click followed by a late systolic murmur. This one is easy to tell from the other systolic murmurs because of the sharp click. Even though these first four murmurs are all systolic, the details will help you tell them apart. Now, let's look at the two diastolic murmurs. The first is aortic regurgitation. Let's take a listen. This is a diastolic murmur that starts immediately after S2, gets quieter, and ends before S1. It is also best heard at the aortic area. The second diastolic murmur is mitral stenosis. Let's take a listen to mitral stenosis. This murmur is preceded by an opening snap in diastole, and then is a rumbling quality murmur that lasts until the next S1. It's heard best at the mitral area. These are really the only two diastolic murmurs you need to know, and they're easy to tell apart by the location where they are best heard, and also by the presence or absence of an opening snap. The final murmur to talk about is a patent ductus arteriosus. When people say this murmur is machine-like, they aren't kidding. It really sounds like a washing machine or a dishwasher. Most importantly, it lasts all throughout the entire cycle, systole and diastole, which easily sets it apart from other murmurs. Great! Now we're going to switch gears and move on to talk about the electrical activity of the heart. If you need a break, now is a good time. Go to the bathroom, grab a snack, whatever you need to do, and I'll be here when you get back. Okay, ready to keep going? Great. We're now going to start talking about the electrical activity of the heart by talking about ventricular action potentials. These are fast response action potentials that are similar to the atrial myocytes, the bundle of His, and Purkinje fibers. The different phases of the cycle are listed here. Phase 0 is the rapid upstroke, which occurs when there is a transient increase in sodium conductance due to the voltage-gated sodium channels opening. Phase 1 is the initial repolarization, which occurs when voltage-gated sodium channels are inactivated, thereby decreasing sodium flow, and potassium begins to flow out of the cell through voltage-gated channels. Phase 2 is the plateau, which occurs due to an inward calcium current through voltage-gated calcium channels and an increase in outward potassium current. These opposing currents are approximately equal and hence the plateau. Phase 3 is the rapid repolarization, which occurs as calcium conductance decreases with closure of the calcium channels, and there is a massive potassium efflux due to opening of the voltage-gated slow potassium channels. This large outward potassium current hyperpolarizes the membrane. The final phase, phase 4, is the resting potential and is the time when potassium influx and efflux are equal. The biggest difference between this action potential curve and that for skeletal muscles is that in the heart there's a plateau of electrical potential, which you see in phase 2. Specialized cardiac nodal cells also spontaneously depolarize during diastole, resulting in automaticity due to IF channels, which we will discuss in more detail next. Another important difference is that cardiac muscle cells are electrically coupled to one another by gap junctions. This allows for depolarization in one cell spreading to adjacent cells and allows for coordinated contraction. As you can tell, the differences in cardiac muscle are important because they allow the entire ventricle to contract in sync, whereas skeletal muscle fibers often contract separately to allow for fine movements. Let's now go through the pacemaker action potential. This only occurs in the SA and AV nodes, and there are some key differences. In phase 0, the upstroke is caused by opening of voltage-gated calcium channels. Which ion was important for ventricular action potentials in phase 0? That's right, sodium. The sodium voltage-gated channels in the pacemaker cells are permanently inactivated to prevent fast upstroke. There is a slow conduction velocity with the voltage-gated calcium channels. In phase 2, the plateau is absent. In phase 3, repolarization occurs by an increase in potassium conductance with inactivation of the calcium channels. In the final phase, phase 4, slow depolarization occurs in which the membrane potential spontaneously depolarizes as sodium conductance increases. This current is known as IF. IF is turned on by repolarization of the preceding action potential. This contributes to the automaticity of SA and AV nodes. The slope of phase 4 determines the heart rate. What things can contribute to heart rate? As a review, it's again catecholamines such as norepinephrine and dopamine increase depolarization and hence heart rate. Sympathetic stimulation increases the probability that IF channels are open. In contrast, acetylcholine and adenosine decrease the rate of diastolic depolarization, and hence it decreases the heart rate. Now, let's begin our discussion of EKGs, as this is a very high-yield topic on the exam. There are entire electrocardiography textbooks, but these next few pages will contain the basics of EKGs that you need to know for the exam. This is a basic tracing of an EKG, which records the net electrical activity in the heart. The P wave represents atrial depolarization. The QRS complex represents ventricular depolarization, and the T wave represents ventricular repolarization. If you're wondering why there isn't a wave for atrial repolarization, that's because it's overshadowed by the QRS complex. The PR segment represents the period between atrial depolarization and ventricular depolarization when the impulse is being conducted through the AV node. The QT interval represents the period of mechanical contraction, also known as systole. The ST segment is normally isoelectric and is important because any changes here can indicate serious cardiac events like ischemia or infarction. The U wave seen here occurs in states of hypokalemia and bradycardia. Let's also at this point go over the electrical signaling as it travels through the heart. The electrical signal begins at the SA node, travels through the atria, then the AV node, moves through the common bundle and then through the left anterior fascicle. Next, it travels through the bundle branches, moves through the Purkinje fibers, and then finally the ventricles. The SA node is the pacemaker with inherent dominance. The next dominant pacemaker is the AV node, which has a delay to allow for ventricular filling. The conduction speed is highest in the Purkinje fibers next to the atria, with the least in the ventricles. Finally, the bundle of His and Purkinje fibers have some pacemaker capabilities, but these are even slower than the AV node. It is important to know since damage to these electrical nodes can cause the others to become dominant in pacemaker control. Now that we've gone over some of the basics of an EKG, let's now talk about specific things that can go wrong. The first is torsades de puentes. This is a very specific form of ventricular tachycardia where the amplitudes of the beats are shifting in a wave-like progression. When you see a pattern like this, you should recognize it as torsades. Also, you should know that anything causing a long QT interval can lead to torsades. Some of these are genetic, but also many drugs lead to torsades. The next section contains some very high-yield information, specific pathological patterns that can be seen on EKG. Atrial fibrillation occurs when the atria do not contract as they normally should. This results in an EKG tracing with irregularly irregular QRS complexes and absent P waves, which is characteristic. It can be a dangerous condition because it can lead to atrial stasis and subsequent clot formation, which can lead to embolic stroke. So it's usually treated with medications such as beta blockers as well as warfarin to thin the blood and reduce the risk of stroke. Here's a question for you. During atrial fibrillation, what is controlling the atrial contraction rate and what is determining the ventricular contraction rate? Well, normally, the atrial contraction rate is determined by the SA node. However, in atrial fibrillation, there is increased excitability all across the atrium, with impulses coming from the SA node as well as other areas of the atria. For the ventricle, the atrial impulses are traveling chaotically through the AV node. The rate is determined by the amount of time it takes the AV node to reset its electrical potential, also known as the refractory period. Atrial flutter is similar to atrial fibrillation, but instead of completely absent P waves, there is a sawtooth appearance to the flutter waves, meaning that they repeatedly go up and down in a predictable way. Treatment is with antiarrhythmics and rate control drugs such as beta blockers or calcium channel blockers. We will cover these in more detail when we get to pharmacology. Ventricular fibrillation is basically total chaos with no patterns. When you see this, it means that the ventricle is not depolarizing in unison like it should, but rather each different area is depolarizing at a different time, so that the heart can't properly pump out blood. This is a fatal arrhythmia unless it is rapidly reversed. Next, we have the different types of AV block, also known as heart block. First-degree heart block is when there is a long PR interval, but otherwise the EKG tracing looks pretty normal. For second-degree heart block, there are two types, called Mobitz type 1 and Mobitz type 2. Mobitz type 1, also known as Wenkenbach, is when the PR interval gets longer and longer until a QRS complex is dropped. Mobitz type 2, on the other hand, happens when there is just a random loss of QRS complex without any changes in the PR interval. The final type of heart block is third degree, which is when the atria and ventricles are completely out of sync and independent of each other. There are QRS complexes and P waves present, but they don't have any relationship to one another. This is a very serious condition that can lead to fatal arrhythmias like ventricular fibrillation. Alright, that was a lot of information about the electrical activity of the heart and how it shows up on EKGs. Since this is a pretty high-yield material for the exam, let's go over it with a few questions. Here's a question. A 54-year-old man presents to your office with 1 day of severe fatigue and weakness. He works as a park ranger in Connecticut. EKG reveals P waves that are completely dissociated from QRS complexes. What is the etiologic agent behind this patient's disease? This is a bit tricky, but if you said Borrelia burgdorferi, you're right. The EKG findings here are typical of third-degree AV block, which can be caused by many things, but one of them is Lyme's disease. When you see that this patient works outdoors in Connecticut, you should immediately jump to Lyme disease, and the causative organism in this case is Borrelia burgdorferi.